There are several basic things about bipolar disorder that are important to know. One, and many of you may know this, there are two well-established types. One is with manic episodes and the other is with hypomanic episodes. There's some controversy about whether this is on a spectrum or whether these are distinct, but the thing to understand is that type 2 is not less severe than type 1. In fact, people who have type 2 have a greater burden of depression than people who have type 1. Bipolar disorder frequently comes with other problems, and that's what makes it so challenging for people to live with because of these other problems that happen. And the other thing is that for reasons not entirely clear, but it may be partially because of genetic overlap, that people who have bipolar disorder also have chronic physical conditions, which make it even more difficult. The most common of those conditions, and I think I'll show you this later, is actually cardiovascular disease. What it means is that you really need to take very careful care of your medical care. How often does it happen? It depends how you count, but the lifetime prevalence is about a little over 2%. So in the United States, that's more than 7 million people. And what's really remarkable is that somewhere between 0.6% to 3.9% of people below the age of 20 have it. That means if you estimate about how many people, maybe 480,000 to over 3 million below the age of 20. So it is, for many people, something that starts when they're young and then is lifelong. Of those who have bipolar disorder, 30% will have their onset before the age of 20. So let me explain this graph. So here's the cumulative lifetime risk of the disorder, and here's the age in years. And so as people get older, there's more and more people who get it. Bipolar 1 in the solid line, bipolar 2 in the dotted line. And then there's this whole area of subthreshold bipolar disorder. Now, what does that mean? It means that people can have episodes that just don't quite meet the criteria. And the criteria are really arbitrary in some ways. So for example, to have a full manic episode, it has to last for 4 days. Well, what happens if you have a full manic episode, but it only lasts for 3 days, right? Who said that 3 is the cutoff point compared to 4, right? So this is the whole cumulative of all of these things. But if you look at the age of 20, that's where the 30% comes from, right? So it's about a third or so will have it start before the age of 20. If you look at the other conditions that people have, substance use disorder, anxiety, PTSD, personality disorders, they're much more likely. This is an odds ratio. You could think of it as this is more than 2 times likely to have a substance use disorder as compared to the general population. One thing about personality disorder, as an aside, I don't even know what that is anymore. And I think that some people have difficulty in modulating their social interactions, their irritability, their social cognition. And people call it personality disorder, and I just don't like that because it makes it sound like somebody's responsible for it. And I don't think people are. I think it's just the way we're built in some ways. But it makes it difficult for them and the people around them. And again, it makes it more challenging for people to find a path of peace and fulfillment if they have these other things, because you really need to pay attention to those other things. I mentioned before cardiovascular disease. For bipolar 1, bipolar 2, even major depressive disorder, it's, well, you know, a little bit higher with major depression disorder. About 1 is about, that would be even with people who don't have it. But with bipolar 1 or bipolar 2, it's more than 2 times the risk of having cardiovascular comorbid conditions. I mentioned earlier, it may be in part because of genetic overlap between cardiovascular risk and bipolar risk. And in addition to that, as many of you know, some of the medications can cause the metabolic syndrome, which is increased weight, increased waist circumference, increased lipids, increased blood pressure. And so that combined increases the risk. And again, it means you really need very good cardiovascular care. The course of bipolar disorder can be quite complex. If you look at, can you guys see my arrow? Can you see that all right? Or no, not quite?
See it fine.
Oh, great. So if you look here, this would be the course of bipolar disorder 1, right? So you have depression, and this is not a fixed pattern, by the way. This is just an example of a pattern. Everyone can have different patterns over time. So people can get depressed, they can then get manic, full mania, go back down a little bit, have rapid cycling between the patterns. Rapid cycling is defined as having 4 or more mood episodes in a year. And if someone has rapid cycling, that can be temporary. Right? It's not like they have rapid cycling forever. For bipolar 2, they don't quite reach the threshold of mania. Here's mania and hypomania. And they have a lot more depressions that happen. And one of the things that's challenging for clinicians to recognize is that people can have mania and depression at the same time. Or they can have manic symptoms and depression at the same time. Or mania and depressive symptoms, right? So these things can be mixed, which is why I think it's so important that clinicians are systematically evaluating how people are doing so they can recognize that. This represents sort of the percentage of weeks spent with mood symptoms or without them, asymptomatic, in like a typical year that people can have overall. What's important about this is that with bipolar 1, there's not a lot of time spent in mania, even though it can be devastating, but it's about 1/3 of the time that people can have either major depressive episodes or depressive symptoms. I mentioned earlier with bipolar 2, it's not less severe, it's just the hypomania is not as severe as the mania, but depression can be half the time that people have. So it's really a great burden for people. And it is relatively difficult to treat in some ways, and I'll explain that later. So it's the depression that causes so much distress. And if you mix the depression with anxiety, with manic symptoms, and people can get irritable and agitated, and of course can think of suicide and even die from suicide. So it's really quite serious. Don't worry about the complexity of this. This is the way people are looking at genes these days. And this is some of the newer genes that are implicated in bipolar disorder. There's particular interest in this one, ACAP11, and that's one of the areas of study that people are doing. So that's the first chapter, just some basics. 2.1% of the population. You have bipolar 1, bipolar 2 with a greater burden of depression as compared to bipolar 1. So let's shift over to the interventions that really can help. And one of the things that I think is important to do is to put the treatments in the context of all of medicine. And the treatments are really pretty good for many people. The difficult thing is that we can't quite match treatments to people. We don't have the biology of that. And so it's very empirical. The first thing is lithium. And John Cade, in the backwaters of Australia, was the first really to find that lithium had an effect in people in 1948. Now, it took until 1972 to be approved in the United States. And part of that reason was that in the 20s and the 30s, people were trying to find a salt substitute and used lithium chloride as a salt substitute, but then people were taking too much and got sick from it. So it was seen as something that was toxic. So it took until about 1972 to get approved by the FDA. And out of all the treatments available, it's the one that seems to have the most beneficial effects in those people who respond to it. And of all the people who have bipolar disorder, it's about a third or so who really benefit from lithium and can take it long term. There is consensus that it is the drug of choice for maintenance treatment, meaning it's the drug that best prevents future episodes from happening. It also decreases all causes of mortality. And of course, it has side effects, especially on the kidney long term, so it has to be carefully monitored to make sure that there's no kidney damage at all. There are other side effects like tremor, which is not pleasant, and also thyroid problems, but those are easily corrected. So it's not the perfect drug, but of all of the medications that we have, there is nothing that actually has beat lithium for the long-term maintenance. There are a lot of antimanic agents, and out of all of these, risperidone, carbamazepine, haloperidol, and so forth, most of them are repurposed antipsychotics. And what they do is they block dopamine as the main mechanism of action. But in here, what I want you to see is that overall, the response is about 2 to 3 times, about 2 times greater than placebo overall. And everyone responds differently to these, which is why, if you're going for treatment or if your loved ones are going to treatment, you may see them get certain treatments and maybe it works, maybe it doesn't. You try one, then try another, and they all have somewhat different side effects. So many times the choice of which one to take is really based on side effects. One thing I do want to mention about valproate. So valproate, as an anti-manic agent, is starting to fall out of favor. The reason it is falling out of favor is that it's not good for women of reproductive age. And more recently, it's found it's not great for men of reproductive age. Also, its efficacy is being questioned, and so you may see that used less often. The other thing I want to mention is that carbamazepine, also known as Tegretol, has a lot of drug interactions, and many people don't necessarily use that these days. What also, if you put all of the data together, the response rates for antipsychotics, as I mentioned before, they're repurposed. For lithium, for the anticonvulsants that are repurposed, and even for all the drugs, it hovers around 50%. That means for anybody, the probability of responding to any one of these drugs is about 50%, which is not that bad. If somebody doesn't respond to one, what's the probability that they'll respond to another? We don't quite know that. Although I'll tell you about a study that we're doing trying to answer that question for bipolar depression. For bipolar depression, there are just a few treatments that are approved by the FDA. And it's a very complicated story once you talk about the antidepressants themselves. Each one of these have an antipsychotic as part of it. So it's olanzapine, quetiapine, lurasidone, cariprazine, lumateperone. With all of these, they have some side effects that sometimes prevent people from using them. So the olanzapine fluoxetine combination, or Zyprexa plus Prozac, is notorious for weight gain. Quetiapine or Seroquel also has weight gain and the metabolic syndrome. I mentioned that earlier, right? The metabolic syndrome is weight gain, increased waist circumference, increased lipids, increased blood pressure. Lurasidone or Latuda, cariprazine or Vraylar, lumateperone or Caplyta, these are all much less likely to cause metabolic syndrome. Also, the one that is most sedating is the quetiapine Seroquel. That'll cause the most tiredness. Now, if somebody's not sleeping at all, sometimes that's not a bad thing, and it can help people sleep. The other thing that's important in this category of treatments is lamotrigine or Lamictal. Lamotrigine or Lamictal is a repurposed anticonvulsant that's approved by the FDA, excuse me, for the prevention of mood episodes. Many people will take it also for the acute treatment of bipolar depressive episodes. And it's questionable if it can be used that way alone. There is evidence that if you mix lamotrigine with lithium, then it might work acutely. Now, one of the things I mentioned is that the antidepressant story is really complex. So the things that are categorized as antidepressants have not been approved for bipolar depression. Nevertheless, because the olanzapine fluoxetine combination, the Zyprexa Prozac, was approved, many people will assume that an antidepressant plus an antipsychotic will work. We're going to be doing a study to test that, and again, I'll tell you about that later. Now, does this mean never take an antidepressant or it's always bad or some ways? Not really. There's consensus and agreement that what probably isn't okay is an antidepressant alone without something that is anti-manic. That's probably not okay. The other thing is that there are evidence-based psychotherapies. And what's really important about the psychotherapies is that when they're mixed with medicine, when they're adjunct to medication, they can make a world of difference. And these are just some of the evidence-based psychotherapies that really can help. Out of all of these, the one that I'm really fond of is the last one, which I like to call Listen to Your Mother. And what that actually means is get a good night's sleep, eat real foods, eat good nutrition, don't smoke, don't take drugs, go outside and be with your friends and socialize. And also the other thing that's really important that our group is starting to study is brush your teeth. Because it turns out that gum disease is not good for your brain. And it's really important to take good care of your teeth. If it's the only thing you remember from this presentation, it's take good care of your teeth. Again, but these interventions are, all of them, including the lifestyle intervention, is what you do between visits in addition to taking medication. That can really help. The other category of treatments is called neurotherapeutics. Really what the neurotherapeutics are, it's applying different forms of energy to your brain. Electroconvulsive therapy is the one that's the oldest of all of the treatments, probably the most effective of these. It can cause temporary memory loss, which is why people don't like it. But modern ECT can be remarkably effective and is probably underused. Repetitive transcranial magnetic stimulation, or RTMS, is rapidly evolving, and there's some new forms of it that can work quite well. Vagus nerve stimulation, actually you have a pacemaker implanted and a wire that goes up to your vagus nerve in your neck, and it stimulates that. That can work. And there's a lot of research done on deep brain stimulation, which is directly stimulating the brain. And then there's more of a surface type of treatment called transcranial direct stimulation. One of the things which you may or may not be aware of is that there's a really good guide for patients and families from the Canadian group, the Canadian Mood and Anxiety Treatment Group, and the International Society for Bipolar Disorders. By the way, if anybody wants to go to the International Society of Bipolar Disorders meeting, it's being held at the end of September in Iceland, so you can look them up. A lot of us are looking forward to going to that. But this is really widely available, right? You can get it from the internet, from canmat.org, and look for the patient and family guide. And it's extraordinarily well written and clear. So I think that can also really help you as a great resource. Chapter 3, Gaps and Hope. One of the things that's happened over the years is that the past 20 years or so is that people are prescribing more antipsychotics and less mood stabilizers. And I just want to show you one thing as an example, which is the proportion of people who are taking lithium. Lithium is in green here. And between 97 and 98, about 30% of people were taking lithium. What's happened over the past 20 years is that's gone down to 15%, replaced by the second generation antipsychotics mostly. Is that good? Is that bad? Are there better outcomes? Nobody really knows. But because there's such agreement that lithium is one of the best things long term, a lot of people are concerned that this may not be the best thing for people, that it's gone down so much. Now, again, you have to acknowledge that lithium has its own side effects and its own problems. It's not perfect, but still it's seen as probably the best maintenance treatment that we have. That's one problem. The other thing is that people are still using a lot of antidepressants and even antidepressants without mood stabilizers or antimimetic agent. So here's the proportion taking antidepressants, 97, 98, and it's gone up, right? 20% to about 40%. Again, I think that's probably not great, but there's still controversy about whether we should use antidepressants at all. Just don't know. The other thing that I think we have to acknowledge that my good colleagues Holly Swartz and Trish Suppies really emphasized, this is back in 2023, that bipolar 2 disorder is still understudied and underdiagnosed, that many people present with depression, but the clinicians don't get a good enough history that someone had a hypomanic episode. There's also, in the literature, there's some studies that say antidepressants alone are fine for people with bipolar 2 disorder, but that is quite controversial. The other thing is pediatric bipolar disorder, and there's still a lot of controversy about that. And there are just not enough treatment studies, and we need to learn a lot more about what works and what doesn't work, and how to carefully diagnose kids who have bipolar disorder and adolescents. And again, I'll tell you there's a path for hope for that. Many people who have psychiatric disorders, including bipolar disorder, just don't have their medical care integrated with psychiatric care. And I think we have to do a much better job of having collaborative care. And again, I will tell you about a potential path to make that happen. The other thing is that clinicians are frequently flying alone. And because they're flying alone, they really don't have a team-based review of how people are doing, their treatment, their progress. They're not measuring things carefully enough. And nobody really knows what the individual clinician is doing. I can tell you that in my large institution, nobody knows what I'm doing clinically. Nobody looks. I really don't get any feedback. And in fact, the only feedback that I get as a clinician from my institution is the proportion of patients who are filling out forms, which is really not useful. So there's another big gap. So how can we address this? Well, what my colleagues and I are doing is we are building something called a learning health network. And it's based on a highly successful model that comes out of Cincinnati Children's Hospital. And they have built 15 of these networks for pediatric diseases and disorders. And we're collaborating with them to build this for bipolar disorder, to actually have a radical way to collaborate between patients, families, clinicians, data people, healthcare systems to get better outcomes. And the vision is to improve the health and well-being of people who live with bipolar disorder across the lifespan. And we're trying to put together a sustainable network that's not a research study. We want to continuously improve care, learn from every clinical encounter, and also spawn innovation and conduct research. And there's a systematic way to do this, to start small, learn from failures, test under many conditions, use quality improvement techniques to be able to identify problems and try to solve them. Also anticipate them and make predictions. We published the outline of this in May of 2023 in the journal Bipolar Disorders. And it's again where it's people-centered. It's not centered around the data. The data are in the service of helping everyone involved. And in fact, it's not even patient-centric, it's human-centric. It's trying to help all of the humans involved so that we can get better outcomes. We currently have 18 institutions that are interested in this and are collaborating together. We've spent the past year designing this, and we're now shifting over to what do we need to do to implement it. We have a sophisticated information technology backbone, but again, it's not centered on the data, it's centered on the people. These are the places that are currently involved with it. We're all really excited that we can actually get better outcomes, that there's a path to constantly learn what's using. And the secret sauce in this is to get all of these different institutions to agree to share their outcomes. In my journey of helping put this together, I was incredibly impressed that none of these healthcare systems know their outcomes. They actually don't even know how many patients they treat. They don't know how frequent people are going to the emergency room or getting hospitalized and so forth. And just imagine that we have built an organization where these different institutions can trust each other to actually see each other's outcomes. And it's in the service of learning from each other. And what the network does is it learns from variation. So if one place is getting better outcomes than another place, the place that's not getting the better outcomes goes to the other place and say, teach me what you're doing. Teach me what's going on. And in the other learning health networks that come out of Cincinnati Children's, the outcomes are so stunning you can't even believe it. But they have a network of 50,000 kids in 106 clinics who have inflammatory bowel disease, Crohn's and colitis. And they looked initially that the remission rate, getting all the way better from an acute bout of inflammatory bowel disease, at the beginning was 55%. And by having this radical collaboration, they raised the remission rate to 82% with no new treatments. And that's what we are aiming to do. We hope that we are able to put the financial model together to that this can work. Currently have some philanthropy, but we have a very thoughtful way to moving forward. And then my hope is that in 2, 3, 4, 5 years, we're able to expand so we can help more people. So that's where the hope lies, to have constant learning and constant improvement in a learning health network. We would work together, we would collaborate, review cases together, be able to help each other, consult to each other, solve the problems in collaboration with patients and their families. Do pre-visit planning, do measurement-based care, and see what's happening overall. This is a map that we were able to come up with what the current system of care is, where it's understanding and preventing, identifying, healing, treating, recovering, and sustaining the treatment. I don't want to go into the details of this, but we were trying to look at the entire system as a system of care. And in the Learning Health Network, we're trying to change that system in order to get better outcomes. So thank you very much for spending your valuable time with me. I do want to be able to take questions in any way the format works. But look, in the first chapter, covered some fast facts, talked broadly about the interventions that can help a lot of people. There's still a lot of gaps, and I think there's great hope with the Learning Health Network that we're putting together. And I will end there. That there is a very good journal from the International Society of Bipolar Disorder, and the name of the journal is the Journal of Bipolar Disorders. And that's because it can be a final common pathway of many things. The genetics, as I showed you just briefly, are highly complex. But certainly brain trauma can also dysregulate the way the brain is working. And people can have a bipolar syndrome after brain trauma. You'd probably still treat it the same way, but again, the point is that there are many paths that can lead to the disorder, including physical trauma to the head. So this happens in all of medicine, by the way, that people will take medication or treatment, and then if they're feeling okay, they'll kind of stop it. People even do that for 10 days of antibiotics. The proportion of people who actually finish and take every pill for a 10-day course is rather low. So it's really no different than any sort of long-term treatment where people feel like, well, I'm doing okay. And I like to think of it as it's like an elephant repellent. If you have an elephant repellent in your house and there are no elephants, well, you don't know if the elephant repellent is working or if there are no elephants. And so what happens is that people will self-regulate and they'll test it. And they'll go, I've been doing okay for 2 years. I'm not sure I need this anymore. I'm not sure it's worth the side effects anymore. I'll just stop it and see. And then what happens is that for many people with bipolar disorder, it usually comes back. So in many ways, it comes down to someone's experience. And I've seen people where they needed to have 6 relapses until they said, I don't like this happening anymore. And maybe I'd like to reduce the probability that it's going to happen again. Maybe the way to do that is to really take the medication. So it has to meet their own goals, right? And I think there's a blend of giving the information. There's also, NAMI is a great source of information. There's also the International Bipolar Foundation that has really terrific information for people. And I think educating people about it, that look, here's the probability if you don't take the meds, and would you like to make that probability half of that by taking the meds? What's your ultimate goal? What do you want to happen? And in many ways, what I think is most important is to ask people what matters to them, right? What is it that they want? What are their goals? And how could they achieve that? And what's going to increase the probability that good things will happen and decrease the probability that bad things will happen, right? And then they could decide what they ultimately want to do. So again, this is the controversy of like, do you give somebody an antidepressant or not? The other thing is that, again, this is why bipolar 2 is still more mysterious than it should be. And this is the other problem. That exact combination, right? A boost bar, Effexor, Lamictal, has never been studied. And many people will end up taking combinations that, we don't know if it helps or not, but the clinician will try to do things that are empirical. And this is why I'm so excited about the Learning Health Network, because we can look at that. Right? We'll have thousands of people, treated with thousands of things. We could try to figure out, well, is somebody doing well? Are they not doing well? Does that combination work? Does it not work? And ultimately, what we'd like to have is that, okay, somebody comes in and we could show 5,000 people just like that person, their treatments and their outcomes. And then have it so that we know, this is probably going to work better than something else. So Lamictal and bipolar 2, understudied. There's one study of Effexor for bipolar 2 depression that's in the literature from a guy named Jay Amsterdam. Nobody's replicated it. We don't know. Buspar or buspirone, again, it's an interesting anti-anxiety agent that's not like Valium or Ativan or that sort of thing. Maybe that's helping. What the combination does, I don't know. But if it's helping, that's fine. I don't care. I think that goes back to what matters to the person. And are they living the life that they want to live? Or are things getting in the way? And if things are getting in the way, what are the potential things that can help? Now, it's sort of very basic. Are you doing what you want to do, and are you happy with that? And are you functioning the way you want to function? Are you living what you would consider to be a good life? So some of that is under a paradigm called motivational interviewing that is frequently used for people who have substance use disorders, right? It's like, what's your goal? Is your substance use helping or not? Is it hurting? Is it helping? What are you getting out of it? And it's the same sort of thing with insight, right? And if you reflect back to somebody, this is what I've observed and I'm concerned, right? And also bring it back to what they want. Eventually people do come around, right? And they do start to realize, this is not good. I don't want to do this anymore, right? I don't want to go back to the hospital if I don't have to. Okay, so, maybe you should get engaged in some treatment that you find helpful. I think it depends. And what I mean by that is that, I have people who are fine. I mean, they're really, I tell them, look, come in every 6 months so you don't forget who I am, right? I want to see you every 6 months. And they come in every 6 months and they're fine, and they're taking the meds, they're living their lives, they're doing okay. They don't particularly need psychotherapy. There are other people where they have dysregulations, problems with navigating through life, relationships, other things that make it so that therapy can really help a lot. And in many ways, I see therapy as having two important functions. One is decreasing stress. It may not surprise you. Stress is not really good for you. And things that decrease your stress, that's good for you. The other thing that psychotherapy can provide are tools to manage stress, also someone's own internal dialogue that sometimes is helpful and sometimes is not, and help people navigate through the world. So if people need those things, then it's very helpful. For other people, group therapy can help, so they start to have more insight of how they relate to other people. So really, I think matching the right therapy to the right person at the right time is what's essential. The fancy word for co-occurring is comorbid. And the earlier that somebody has the onset of their bipolar disorder, the more likely they have comorbid ADHD. And in fact, sometimes what happens is ADHD comes first when they're young. For the very young people who have bipolar disorder, and that's a whole nother controversy, but if they have it either prepubertal or in early adolescence, the proportion who have comorbid ADHD is very high. That presents a particular problem because the treatments for ADHD can destabilize people who have bipolar disorder if you don't give it correctly. And the trick with treating comorbid ADHD is to start on stimulants very low and go up very slowly and watch carefully for any sort of dysregulation. But it also can be life-changing for the better when people are able to regulate their attention. I like to point out that ADHD is not a deficit of attention, it's a dysregulation of attention. That's why you'll see people who have ADHD can concentrate and spend 6 hours on video games because it's rewarding and they can hyper-focus on that. But they can't get off of it, right? It's dysregulated. They also can't regulate their attention and pay sufficient attention to those things that are boring or routine, right? And then they're disorganized, they can't get that sort of things done. But the treatments for ADHD are extraordinarily useful. You just have to be very careful with them. So I actually don't know enough about it to give you an intelligent answer. There are some studies of just ADHD and neurofeedback that turn out to be positive, but I don't know about the use of neurofeedback in the context of people who also have bipolar disorder. But as I said before, if it helps somebody experience less stress, I'm all for it.